about life. Rather, I would say there is one good thing about life and one bad thing about life. One good thing about life is that it ends, and bad thing about life is that it also ends. But whosoever has born has to die one day. But the problem with the death in cancer patients is that the fear of death is very prolonged. Most of the deaths, we say the best death is when you die off in your sleep, or it's a sudden death when you do not realize that you're going to die. But sadly, for cancer patients, that is not true. They realize that first of all, the name cancer itself is very scary. So once the patient gets that I have cancer, or someone tells him that you have cancer, there's a constant scare that, oh, I'm going to die one day, but the death is not known when it is going to come, and person waits for the death every day. And that itself, the life itself becomes so miserable, the person wishes to die for one day and wishes that death comes very soon and it comes calmly. But sadly enough, that doesn't happen. So in between the death and the life, or the miserable life or the scare of death, there is ICU care, for which we have already seen in our discussions previously in our today's conference. As it was mentioned, the 30% of the patients who get admitted to the hospital, they die in the ICUs. And in Onco setup, it is also almost the same number, as they say, around 15 to 28% patients in Onco ICUs, they die during the treatment or once they get readmitted because of some complications. So for moving forward with our today's discussion, first I will present a brief case, and then we will continue our discussions on the lines of the cases. So first patient is a 50-year-old male patient with cancer, CA tongue with post multiple lines of treatment. He is on palliative chemo. He is on multiple chemotherapies. He is on palliative chemotherapy. He was diagnosed with this illness on 7th of April on 2022. But presently the lesion is surgically unresectable and the patient is on palliative chemotherapy. Patient was admitted on 2nd July 2024 with the breathing difficulty along with other investigations. Morning ABG at the time of admission showed CO2 narcosis, and because it was difficult for the normal airway to continue for the patient to manage, emergency tracheostomy was done. Cardiovascular evaluation showed anterior wall MI in ECG and ejection fraction of only 25% with severe hypokinesia in the left anterior descending territory. Chest X-ray also showed right lung was completely destroyed and hyperinflated left lung. Patient was put on ventilator and we were not able to wean the patient even and patient continued to retain CO2 on CPAP trials with FiO2 of 40%. Patient otherwise was conscious, oriented and vitals were stable. PEG feeding was started, family counseled about the basic life support and on further treatment, and no other further treatment was available according to the primary treating team. Patient kept on asking about his vitals, his ventilator status, and he wanted to go home after the recovery. So in this scenario, we have a few questions that promptly come over to our mind. Uh, so, Dr. Deven, I would like to start with you. Are there any further investigations or any consultations with our any primary teams or any other specialties in our branch that may help us to go forward in deciding whether to continue with the intensive care of such a patient, or shall we shift over to the palliative care?
It is very difficult to decide. There is no single investigation which can tell us whether this patient is going to survive or not. Once the diagnosis of cancer is made, sometimes it becomes easier for the family to understand that maybe the end is near and the acceptance levels may be a bit higher. So, in such cases, what we generally try to do is to do a PET scan just to evaluate the extent of the disease. So, sometimes if there are multiple metastases, the prognostication of the patient does become easier. And like in this patient, now the patient is conscious, patient although on tracheostomy, but the patient is conscious. Then I think this is the right time when we should discuss with the family the need for palliative care, and by foregoing the further aggressive care, so called. But having said that, in India, scenario is very, very different. So we do not have any particular guidelines which can guide us for and which can apply to all the patient. So like we are talking about, when we are talking about aggressive care also, we talk about bespoke critical care. So that means critical care individualized for that particular patient. So that is also very, very true whenever we are talking about palliative care. Each patient will have separate demands or separate needs rather, and similarly the family will also have separate needs. In India we have got the problem is that it is not the government which is paying most of the times, but it is the patient's family who is paying out of their pocket. It is their wishes also which we need to address. It is not only about the patient's wishes, it is about the family's need also. So many times we do feel that the patient is very critically ill. Like in this case the patient is still conscious, but sometimes we have patients who are not conscious or comatose. In those patients also, when the family demands that we continue care or we continue aggressive care, it is very difficult to withhold treatment. 2 3 days ago, I'll just give you an example. 2 3 days ago, we had a similar patient who is on mechanical ventilation, 87-year-old, recently diagnosed with CL lung. We could not get the PET scan done, so we don't know whether the patient had metastasis or not. Now presented with multiple acute infarcts and got intubated, tracheostomized, vasopressors, renal failure on dialysis. Now the family wants complete aggressive care. So we cannot deny that. We decided, all of us decided, we went to the family, and I told the family that the patient's outcome seems very, very poor. What she told me, the patient's daughter, what she told me, am I not entitled for a to think about a miracle? So if I feel that maybe a miracle can happen for my father, am I not entitled to that? So we do not have an answer to that. So we cannot take away even the 1% hope whatever she has, and if she believes in miracle, we cannot simply take it away from her. So if she wants to continue, we have to agree to that.
So thank you, Dr. Akhil. So that means the communication with the family and the acceptance of the family plays a big role. But along with that, as in this patient of Dr. Akhil and ours, the patient is conscious, we need to involve the patient also. We need to maybe we can enroll a psychologist along with this to address the needs and talk to the patient, because ICU doctors, we may feel that they are not well equipped. So we can enroll a psychologist along with that. And Dr. Akhil, do you think any pre-written will, because a patient of cancer patients, they come to know that the death is imminent many a times. So is there any written will or any DNR signed by the patient would be very important, because the patient's family would not be able to understand how much trauma or the trouble the patient is going through. Patients, the process of dying is killing the patient before the death. So any decision the patient can make when he is conscious or when he is not actually on ventilator, will that make any difference for withholding the life supports?
Definitely, it will make a difference. But in Indian scenarios, the concept of living will is still at the baby stage. It is not very well understood as of now. In 2018, ruling by the Supreme Court, now they have tried to make a process, but then the process again is a very tedious one. But if a living will is there, it will be definitely helpful as the patient is conscious and able to make his or her own decisions. It will definitely be helpful, as well as it will ease the burden on healthcare system as well as on the physician as well. So most of the times we are also in a dilemma that whether to go ahead with the aggressive treatment or slightly be on the back foot or withhold the treatment. The family is also very confused because they say that we are in a panicky situation, whatever you will guide us we will go ahead with. Most of the time this happens, but if definitely there is an informed consent or a willing living will or a order, that we can definitely honor. That also goes with the basic principle of medical management, the autonomy, that the patient has been informed about his condition and he has taken a decision regarding his own process. He wants a dignified death and he wants some treatments to be done and some aggressive treatments not to be done. That is definitely to be honored and that is always helpful.
Dr. Devan, you would also agree that such a case, even it will be easier for the health professionals to put their point forward with the family?
Actually, we have got a tuber board, and like we have also got a palliative care team in our hospital. So, as a general rule, so all our oncologists, while looking at the patient in their OPDs, they educate them that such a provision is available now. And since you are suffering from this particular disease, if you want to take this chance, or if you want to go ahead and write an advance directive, you can do so. But till now, it has been more than 6 years since this directive have come out. I have not seen a single patient coming ahead and showing us an advance directive. So obviously, like Dr. Akhil was also mentioning, the process is still difficult. It is in the stages of nascency, and still the education or the patient awareness is still not there, and people are still not that actively involved in their care. And even if they write the advance directive, if the family member does not come forward and shows that to the doctor, then it becomes very, very difficult.
So I think there are two good take-home messages from this case scenario, that communication is very important, and in case we can have a written will beforehand, that will be really helpful for professionals to communicate with the family. That brings me to the second case. A 69-year-old male patient with pre-existing disease like diabetes, hypertension, metastatic pancreas disease with metastasis to liver. Patient was diagnosed with adenocarcinoma of pancreas on 3rd of October 2023. And was started on chemotherapy. Patient was admitted to the hospital on 1st July 2024, approximately 8 months later, with the complaints of abdominal distension, constipation, and was passing flatus. There was a history of multiple episodes of subacute intestinal obstruction. CECT abdomen was done on 4th of July, which showed dilated jejunal and proximal ileal loops, partial small bowel obstruction. Surgery was unlikely to be beneficial, hence end of life care discussion was held with the family 5 days after the admission. Patient is now on palliative chemotherapy. For pain relief, the patient was started on tramadol, paracetamol, Drotin, and fentanyl infusion. So in this case scenario, Dr. Deven, do you think the patient family, when it was counseled for end of life care at the 5th day, do you think it is too soon or it is too late when we already know the poor prognosis? What's your take on that? Is it too early or it is too late, or
See, I
can
think
other way be there?
the primary responsibility lies with the primary physician or the oncologist in this case. So they have got the experience, they have got the know-how, and they have been treating the patient for a prolonged period. So they know what the outcome is. And especially once the patient gets into critical care or gets into ICU, and he has or she has already developed multi-organ failure, I think it is better to start such discussion at an early stage, because again, like I said earlier, we need to give families some time to understand. They are not going to write this write off their patient in a day's time or 2 days time. So they need to have some time. I think such discussions should be initiated early, maybe at a softer level in the initial phases, because you need to be receptive to their ideas also. It is going to be a two-way communication. You need to evaluate what are their needs also, and depending upon that, you need to push it forward.
So we must take time. According to the literature, I would just add a line that they say approximately 2 weeks time from the patient's admission and once the ICU care has been started. If we know the prognosis is poor, it takes approximately 14 days. Now you must take approximately 14 days time to prep the family and for doctors to make up their mind and primary team to make up their mind that it is not going to make much of the difference.
Like I was telling you, we cannot simply rely on the Western guidelines
Yeah,
and
absolutely,
literature,
absolutely.
because things are different in Western countries. Here, the patient is paying from out of their pockets. So if we wait for 2 weeks,
14
yeah, so the cost of therapy in an ICU like ours is 1.5 lakhs per day.
Right.
So the patient is going,
Already
or the
drained out
family,
of
yeah,
it.
is going to end up paying 30 lakh rupees by the time that 14-day period come in. So again, we have to have our own guidelines, and again, we have to have more individualized care depending upon case to case basis. We cannot simply just rely on the guidelines and wait till 14 days. We need to start it early.
Yeah, but at the same time, we cannot even refuse the admission to such patient. We have to admit the patient.
We should definitely not refuse the admission. We have published data from our hospital multiple times, especially in onco critical care. It is very, very difficult with the kind of advanced care we have. So it is obviously the underlying disease process is important, but the acuity or the severity of illness, the acute illness with which the patient has presented, also plays a huge part. So first 48, 72 hours, many times we have seen even with patients with advanced cancer, You give them good aggressive care for first 48, 72 hours, and many times they come out of it. So we cannot, or we should not start to play God. We cannot predict that every patient who is coming to the ICU is going to die, and we simply cannot deny admission just on the basis of the fact that the patient is having cancer. So in a private setup like ours, we don't follow that, and I do not believe in that.
Dr. Deven, you have already answered my second question, which was going to be that why start with the chemotherapy for such cases? You have already said that we cannot deny the chance.
Yeah,
so the chemotherapy has to be there. So I'll skip the next question and go to the few general questions regarding the palliative care. So Dr. Akhil, again, the question comes to you. What is the palliative care in ICU and how is it different from intensive care? Where do we draw the line?
So to begin with, first a little divergent view about the previous question. See, I am working in a tertiary care center. I have patients paying from their pocket. I have other patients for whom government is paying because of some entitlement of their job. Now, it is nothing against anyone, not the government, not the patient, but the scenario which I regularly see is when the patient is paying from pocket with a bill of 1 to 1.5 lakh per day for a intubated and patient on CRRT. Most of the time after 3-4 days of therapy they want to withdraw it, or initially they give DNI or DNR more easily. But when the government is paying, we have all the consents, go ahead with every treatment, we want to fight till the last breath. So that is one factor which comes in a lot in our Indian scenario.
So you want to say the finances play a big
Finances play
role
a bigger
in
role over
deciding
here in
about
Indian
when to
scenario.
start with the end of life care or the palliative care, you want to say.
As you see, palliative care is not a consequence of, or it is not sequential to intensive care unit, as is your second question as of now. Intensive care and palliative care go hand in hand together simultaneously. As soon as you start intensive care, you should be thinking about palliative care as well. So that is a process which goes in hand by hand, not in a sequence. So as the patient is entering the ICU, we should be thinking whether we need to go for palliation or aggressive intensive care. So that is where the answer lies. It is something between, there is, on one hand there is passive euthanasia, on other hand there is aggressive intensive care. Somewhere in between lies the palliative care. So that is where the answer.
So there are always a few overlapping areas, you want to say,
Indeed.
rather than a clear-cut demarcation that this comes under palliative. So that brings to me another question which was due to follow, that where is the role of high frequency nasal ventilations or non-invasive ventilation and the intervention lines or indwelling catheters. So can we also put that under as a overlapping part, or can we say that no, this part comes under intensive care and when palliative care has started we will not use that?
There is a lot of overlap. I will totally agree with Dr. Akhil. Like we have charted a form. It is a 3-page form, and it is like a menu card. So we give that menu card to the attendant, and they can simply pick and choose each of the things they want for their patient for palliative care. Obviously, a team of doctors is sitting with them to guide them, to explain it to them what are the implications of each and everything. But in a setup like ours, it is more of attendant driven care rather than doctor driven care. So we are there to guide them, we are there to hold their hands, but at the end of the day, it is the decision of the family members that what they want to pick and choose. So in that, it starts from simple like total parental nutrition, blood and blood products, vasopressors, renal replacement therapy, putting of central lines. So all those the things are mentioned in that, and they can pick and choose what they want for their particular patient. So that is why I was telling that more of an individualized patient care. So we do not have a fixed criteria that for okay for all the patient we would not put HFNC, or we would not put the patient on NIV, or we would not give them vasopressors. So again, we explain to the attendant, depending upon the patient's condition, we ask them or we guide them that this is what is required for your patient. You should go for this or you should not.
Dr. Deven, I'll just request you to add on the details for the next question to the same argument. That is there any particular criteria that you look for in a patient who is sick to go ahead with this kind of discussion that you have just mentioned?
Again, since we are sitting in an onco critical care conference, for if the patient is already a diagnosed case of cancer, especially a metastatic cancer, this thing becomes much easier. But when you are working in a general medical ICU, you will have so many patients with advanced or a malignant stroke or patients with chronic liver disease, or patients with advanced ILD, with multi-organ failure. It is much more difficult to get to that point in such a patient. So, but yes, again, a team of doctors in which the primary responsibility is of the intensivist, like we have got a more of a closed ICU. So the primary responsibility is of the intensivist, along with other physicians or other specialty consultants who are looking after that patient. First, we have to decide. See, it is very, very important that all the consultants of different specialities who are looking after the patient, first of all, they have to be on the same page. Many times that also happens that one consultant will say that, okay, maybe kidney to theek hai, kidney to shayad 3 दिन में ठीक हो जाए, तो patient भी improve हो जाए. But all of us have to be on the same page, and then only we talk about palliative care with the attendants. If any of us believe that yes, the patient is still salvageable, we do not talk
Like
about
one
it.
patient, one doctor may say that patient may come out, other may say no, there are 5% chances, third
Yes,
person may come
exactly.
saying 15 to 20%
And
chances.
unfortunately, there is no formula to
Evaluate that. I
Team has to
totally,
be on the same page actually.
team has to be on the
I
same.
remember a patient of septic shock with advanced CA rectum post-op case, and my oncologist telling me, Dr. Akhil, this patient is not going to die of CA rectum over like next 6 months. You think about your sepsis, treat that.
So
So that
those
is
are the
where the
kind of
problem
problems
is.
that come up many times. So present day scenarios, respected sirs, we have an ICU team that is backing up as a palliative care. We do not have two different teams in Indian scenario.
We
where
do have in our hospital,
you
we
have.
do have, but obviously critical care is a part of that palliative care team.
Okay. So do you think there are any further technical advancements or teaching or any more things that we can put forward to our intensive care doctors, like psychoanalysis or teaching something regarding psychology that may help them empathize with the patient and make a better palliative care physician in matter of counseling the patients and families?
The communication per se is a acquired skill. It is not an inherent skill. So it grows with time. As you get a little senior, more experienced, communication definitely grows.
Can we put in some criteria
can-
when in the beginning so that they learn from those things?
Not the criteria actually, but more of a training of how to talk and how to break bad news. That will definitely help. The intensive care physicians, especially the resident and the attendings working at a junior level, they are overburdened definitely. We have a lack of manpower in intensive care and more so in palliative care. So they are overburdened people, and as soon as they hear that this patient is a cancer patient who has given a DNI consent, probably the focus is gone, and focus is gone to more aggressive patient where they think they can save life. So that inherent training has to be there, that these patients are equally important, and definitely we need to care for them. So that demarcation between intensive care and palliative care has to be there. But then these patients are important, and care more so of psychological care, spiritual care, family care. You need to take care of family's emotions as well. So that has to be there.
So,
I believe, just excuse me, I believe that any hospital which has got a onco critical care unit should have a palliative care team. So, and it should be a multidisciplinary team, and it should have some social worker, some maybe priest, or some somebody from some
chaplaincy and all that
religious
plays a role.
religious person. So that kind of team has to be there. So then only you will be able to give a comprehensive care to a oncology patient.
So, Dr. Akhil, I would just request you to mention a few other kinds, like CO2 narcosis we have seen and subacute. There are a few other conditions or criteria which you would see in patients where we would like to consider shifting to palliative care. Could you just mention a few such conditions?
See, a cancer patient may be presenting to ICU in two ways. One is underlying comorbid conditions. He may be a diabetic presenting with DKA, underlying CAD presenting with left ventricular dysfunction. But these DKA, these left ventricular dysfunction, these acute on chronic kidney disease patient, they are more likely to decompensate early and not respond to therapy further. These are a few conditions. Then these patients can present with severe dyspnea, severe pain, anxiety, fear psychosis as well. So these are a few situations where, as a intensive care physician, you need to think more of palliation and not intensive care. You need to elevate the symptoms, treat dyspnea as a symptom. You cannot treat the underlying disease, treat pain. And if the comorbid condition is deteriorating to a bigger extent, you can definitely explain the family as well that probably this patient is not going to make out, and we can think of palliation there.
Right. Sir, just a last question to summarize the thing. I would just like to know that what are the benefits if we combine the palliative care as we have the same team looking to continue to go? What are the benefits of providing a palliative care or towards the end of life care to a patient who is on intensive care and where we feel that patient may not come back and patient is going to
And
die?
it is a part of palliative care is a part of critical care right now. So you cannot separate the two. So it has to be like Dr. Akhil also mentioned that it is a continuum. Rather than separating the two things, it has to be a continuum. By that you can reduce the agony, you can reduce the pain, reduce the suffering, and then it will save the cost. And rather than prolonging the suffering, and it is not only the patient who is suffering, it is the family also who is suffering, and family is suffering not only emotionally but financially also. So you once you incorporate all these things in your treatment plan, it is going to save all these things.
So thank you, panelists. With this, I think the take-home message is the good communication, sympathizing with the patient, empathizing with the family, and giving a patient who is dying a dignified death. I think that's all we can do for the patient. Thank you so much.